Hi guys, welcome to today's session. Today we are here to talk to you about the previous year questions of FMG exam. So just give me a minute. Let me see whether I'm audible and visible to you properly. Okay, great guys. So I will not be kind of visible to you, but my screen would definitely be visible to you, and I think that's more than enough. So what we are going to do, today we are going to talk about the previous year questions of the FMG exam. We are going to cover a couple of them. I will just start by talking to you about our platform. So who am I? I am Dr. Pawan, and I am basically an educator on Unacademy platform. Now, what is Unacademy? Unacademy is a place where you can kind of come and learn and prepare for all the other exams. NEET PG is one of the sections of that, and I basically teach general surgery on this particular platform. Now, in Unacademy, what you can have a plus subscription where you have multiple kind of your structured courses which are present on the plus platform. You can definitely enroll over it if at all you wish to. And then if at all you wish to have an academy along with a prep ladder, you can go ahead with an iconic subscription. This is again one of the things which you can definitely go for. If at all you're interested in that, you can go in for an academy daily tests, which are absolutely free. All you need to do is that you just need to download the app and you can access to a wide range of questions and the tests which are kind of over there. And as we are conducting this particular session on the YouTube, which is kind of free for all of you guys, in the similar manner, we also conduct free sessions on our app, which are called as the free live classes. So you can just have a look at that as well. That is also something which is going to be beneficial for you guys. So for that, you'll have to download the app and you can access the free live classes on the Unacademy platform. So guys, yeah, you can just have a look at that. And for now, let's kind of start with the questions for today. So yeah, what do you think, guys? Yeah, so here we are going to talk about a couple of questions, previous year questions of your FMG exam. So all these questions which I have taken, they are basically from the FMGE 2018 paper. So let us kind of discuss that. A patient with a heavy drinking of an alcohol presents to you with a multiple episodes of vomiting and hematemesis. What is the most likely diagnosis of this particular patient? So what is the answer over here? Is it like the patient suffering from a Mallory-Weiss syndrome, esophageal carcinoma, achalasia cardia, or the Boyer-Rees syndrome? What do you think, guys? What is the answer over here? If you tell me that this is a patient who is suffering from a Mallory-Weiss syndrome, you are absolutely correct. So let us kind of understand this particular question. So here what you have, here you have a man who has basically drank a lot of alcohol, and obviously with the alcohol he would have had the food as well, right? Yeah, that's fine. Now what happens, you guys know that whenever there is a lot of alcohol drinking, you tend to vomit. So following this, obviously there's going to be maybe a vomiting, but whenever you vomit, okay, whenever you vomit, you have to do it with the open glottis. In this particular man, the problem is sometimes this vomiting can happen with closed glottis. Now, this is something which is of a problem. So here there is a vomiting with a closed glottis. What is it called as? It is what is called as a retching. Okay, what is it called as? It is what is called as a retching. Okay, so this is what is called as a retching. So if at all the patient undergoes a vomiting with a closed glottis, ultimately what is going to happen? There is going to be an increase in the intraluminal pressure. It means that the pressure which is basically present inside the lumen of the esophagus, that is going to rise. And because of this, what is going to happen? Something is going to happen. Now, as you know, that all of us are the humans and everybody responds to the pressure in a different manner. In exactly the same way, the esophagus of a patient handles, esophagus of different patients handle the pressure with different outlook. So if at all there is an increase in intraluminal pressure in the esophagus, inside the lumen of the esophagus, either there can be a longitudinal tear or there can be a through and through rupture. Okay, so either can be a longitudinal tear or there can be through and through rupture. If at all there is a longitudinal tear, what happens? This is something which is called as a Mallory-Weiss tear. And this is a patient who is coming to you with vomiting and bleeding. Okay, so yeah, it is basically going to come to you with an upper GI bleeding and the vomiting. Does it make sense to you guys? I hope it makes sense. So because of the longitudinal tear, the patient is going to come to you with an upper GI bleeding and the vomiting. That is what is your Mallory-Weiss tear. And if at all there is a through and through rupture, then what is going to happen? The patient is going to land up with something which is called as a Boyer-Heave syndrome, which is nothing. It is basically coming to you with an esophageal perforation. Okay, I hope it makes sense, guys. So I'll just repeat it, guys. over here, what is happening? There is a patient who has drank a lot of alcohol and the food and blah, blah, blah. Because of this, what is happening? The patient is undergoing a vomiting. But this particular vomiting is against the closed glottis. The glottis is kind of closed, and because of this, there is a rise in the intraluminal pressure. Because there is a rise in the intraluminal pressure, the esophagus a longitudinal tear, the longitudinal submucosal tear. Because of this, the patient might have a bleeding along with the vomiting, and this is what is called as a Malady-Weiss tear. But if at all there is a through and through rupture of the esophagus, the patient lands up into Boyer syndrome, which is basically an esophageal rupture. Okay, I hope it makes sense. It is a very, very simple thing, and you definitely need to understand this. Right. Now, with this, let's move on to the next question of the day. The next question which I have for you guys is, a 60-year-old man undergoes a TURP. Okay, the patient that has been subjected to the TURP, and 3 days, after 3 days, the patient basically is having an altered kind of consciousness, and the patient is kind of drowsy. What is the most probable diagnosis of this particular patient? Okay, so I'm really sorry, this is not the altered sensitiveness, it is the altered sensation. Okay, so it is altered sensation, and the patient is kind of drowsy. Just give me a minute, guys. Just give me a minute. Yeah. So here it is not an altered sensitiveness. The patient is kind of having an altered sensation, sensorium, and the patient is kind of having drowsiness. Okay, that is what the patient is having. So if at all this is what is the patient is suffering from, what is more probable diagnosis in this particular patient? Is the patient is having hyponatremia, kind of stroke, or meningitis due to the spinal anesthesia? The answer is very, very simple. The patient is suffering from hyponatremia. Now, what exactly is happening over here? In this particular question, what they're trying to tell you is something which is called as a TUR syndrome. Okay, so they're trying to talk to you about the TUR syndrome. Now, what is this TUR syndrome, guys? This is what is called as a dilutional hyponatremia. Hyponatremia. Now, before we talk about this, you need to understand that, okay, what you have? You have, let's say, a prostate gland like this, and this is your urethra. What you do, you basically go inside and you start resecting this particular prostate gland. And when you start resecting the prostate gland, what is happening? There is a lot of bleeding which is happening from this particular prostate. Now, what you need to understand, during TURP, you have to subject the patient to a lot of irrigation. Okay, you have to subject the patient to the irrigation with the fluids and everything, and this fluid may be absorbed through these kind of blood channels. Are you able to understand this point? This particular fluid may be absorbed from the blood channels, and this might enter into the blood vessels and ultimately lead to an increase in the intraluminal volume, intravascular volume. I hope it makes sense. The irrigation fluid is absorbed by these open channels, open capillaries, which are basically present in the prostate, right? And because of this, what is happening? Because of this, the patient might land up into hypervolemia. And because of this, the patient will develop something which is called as a dilutional hyponatremia. So what do you understand by dilutional hyponatremia? Dilutional hyponatremia. This basically means that the sodium, if at all you talk about the absolute level of the sodium, that is basically the same. But because the excess amount of the fluid is entering into the vessels, there is a relative depletion in the value of your sodium. I hope you're able to understand this point. Because there is a excess of the fluid which is entering into the blood vessels, the concentration of the sodium in that particular fluid is relatively decreasing. And that is what is called as a dilutional hyponatremia. And that is why the patient comes to you with the symptoms of sodium deficiency, which is altered sensorium and the drowsiness and the weakness and blah, blah, blah. I hope you're able to understand this point. This is what is a dilutional hyponatremia. This is what is called as a TUR syndrome. And if at all this is something which is happening, how do you manage? What is the treatment for the TUR syndrome? How do you manage this? So the treatment for the TUR syndrome is that you have to go in for the fluid restriction. Okay, you have to go in for the fluid restriction, and you may have to go in for the diuretics. Okay, so fluid restriction and the diuretics, this is how you'll basically manage a patient of a TUR syndrome. And if at all it doesn't respond to this, then you may go in for the sodium supplementation. You may go in for the sodium supplementation if at all this doesn't kind of respond. Okay, that's it. Now let's move on to the next question, guys. So what is the commonest site for the brachial cyst? What do you think, guys? Is it like the lower one-third of the sternocleidomastoid muscle on the anterior border, lower one-third of the sternocleidomastoid on the posterior border, upper one-third of the sternocleidomastoid along the anterior border, or upper one-third on the posterior border? So if at all you say that, you know what, the answer over here is option number C, you're absolutely correct. So what you need to understand is that there are two things. One is basically called as a branchial cyst. Now, what is it? Obviously, it is a cyst and it is a congenital cystic lesion. So, what is this? This is basically a congenital cystic lesion, which is kind of present over here. And this is basically present on the anterior border of sternocleidomastoid muscle. Now, what you need to understand over here, what is this branchial cyst? So, this is basically a remnant of a second branchial arch or pouch or whatever. So, it is a congenital remnant of second branchial arch. Okay, so what is happening over here in the with the congenital remnant? So what is happening? You have a sternocleidomastoid muscle, and along the anterior border of the sternocleidomastoid muscle, there is a kind of a swelling which is kind of present, and the location is between the upper one-third and the lower two-third. It is very important, guys. Okay, so this is what is a branchial cyst. It is a congenital swelling which is basically present on the anterior border of the sternocleidomastoid muscle between the upper one-third and the lower two-third of this particular sternocleidomastoid. This is what is your sternocleidomastoid muscle. Now, what you need to understand, another kind of a congenital remnant which might occur is Bronchial Fistula. Okay, so patient might have a Bronchial Fistula as well. So if at all there is a Bronchial Fistula, obviously there is going to be no swelling. And here the patient is going to come to you with an intermittent kind of serous discharge. Serous discharge from this particular opening. Now, a very, very important point which you need to understand, where is this, what is the position of this branchial fistula? So what you need to understand, this is also present along the anterior border only, but this is basically present between the upper two-third and lower one-third. Very, very important, guys. So this is what is your branchial fistula. And I just told you that the branchial cyst is basically present between the upper one-third and the lower two-third. I hope it makes sense, guys. Cyst is between the upper one-third and the lower two-third. The fistula is basically between the upper two-third and the lower one-third. Okay, right? Now, with this, let's move on to the next question. The next question which I have for you guys is, dye for the sentinel lymph node biopsy whenever you are performing it for the carcinoma of the breast. Where do you inject this particular dye? So, do you inject it in the axilla, in the tail of Spence, in the nipple areolar complex, or near the tumor? So, this is one of the controversial questions, not exactly controversial question, but you do not have a straightforward answer for this. Now, if you see the answer to this, the best possible answer to this particular question is near the nipple areolar complex. Now, what you need to understand is that, first of all, what is this sentinel lymph node biopsy? Sentinel lymph node biopsy. So this can be done for many tumors. What you need to understand over here, if at all, let's say there is a tumor, okay, so whatever the lymph node drainage from this particular tumor is, it is first going to one sentinel lymph node. It is going to the first sentinel lymph node, and once it reaches to the sentinel lymph node, from here it is going to the different lymph node stations. Okay, so I hope you are able to understand this point. So there is a first, which is a sentinel lymph node. So what is the sentinel lymph node? It is nothing. It is the first draining lymph node from a tumor. That is what is a sentinel lymph node, right? Now what you do, you take this, you send it for the frozen section. You send it for the frozen section. If at all it comes out to be positive, or it comes out to be negative. If at all it comes out to be positive, you go ahead with a axillary lymph node dissection. You're going to go ahead and do an axillary lymph node dissection, and if at all it comes out to be negative, then you avoid the dissection. You avoid the axillary lymph node dissection. Okay, this is how you basically use this sentinel lymph node biopsy. Now, what this particular question is trying to ask you, whenever you are performing it for the carcinoma breast, where do you kind of inject it? Do you inject it near the tumor, or do you inject it kind of near the nipple areolar complex? So what you need to understand is that there is a controversy. Even your 11 Billy says that, okay, you may inject it near the tumor or you may inject it near the nipperalia complex. But ultimately, the 11 Billy says with the conclusion that it is the more appropriate position is near the nipperalia complex. Okay, so please understand this point. It is not a very, very clear cut distinction, but usually we prefer to inject it near the nipple areola complex. And that is why you should mark the C as an answer. Okay, I hope you are able to understand. Right. Right. Now let's move on to the next question, guys. So next question which I have for you guys is uh, there's a patient who complains to you with a painless swelling over the face with difficulty in the swallowing. The appearance of the face is shown to you guys. So here there is a swelling which is present. So what is the most probable diagnosis of this particular patient? So is it like a parotitis, acute parotitis, carcinoma of the parotid gland, angioedema of the face, or the acute sialadenitis? Okay. So yeah, what do you think? What is the answer over here? If you say that the answer to this particular question is carcinoma of the parotid gland, you are absolutely correct. Because just look at this particular swelling line. It is not a parotiditis, right? It is not a parotiditis. It is a kind of a bossulated kind of a swelling, which is a tumor. It looks like a tumor. So yes, definitely it is a parotid gland tumor, which you are basically looking at. Okay, right? So this was the kind of question which was asked to you. Now, you most probably, okay, if I just ask you what is the most common tumor of parotid, what is the most common tumor involving the parotid gland? The answer over here is pleomorphic adenoma. Pleomorphic adenoma. Most probably the answer is this. Now, what you need to understand, let's kind of talk about the treatment of the pleomorphic adenoma. So here, one thing which you need to understand is that enucleation of this pleomorphic adenoma is contraindicated. You do not perform the enucleation of the pleomorphic adenoma. What is the treatment of choice? You go in for the superficial parotidectomy. Go in for the superficial parotidectomy. Why? Because usually it is basically involving the superficial robe of the parotid gland, and that is why you have to go in for the superficial parotidectomy. I hope you are able to understand this point. If at all they tell you that, you know what, there is a medial deviation of the uvula, if at all they give you in the question that there is a medial deviation of uvula, then what you need to understand, this is a kind of an indicator that the deep lobe is involved. It basically indicates that, okay, the deep lobe might be involved, and because of this, you have to go in for the kind of a total conservative parotidectomy. What do you understand by total conservative parotidectomy? It means that you are removing just the parotid gland. You are not removing or you're not damaging the facial nerve. That is what you mean by a total conservative parotidectomy. Does it make sense? And finally, if at all there is a pleomorphic adenoma which is coming to you with a, let's say, along with this, there is a facial nerve palsy. Anything which is indicating of a facial nerve palsy, or let's say there is a pain in the pleomorphic adenoma, it is basically trying to tell you that, okay, this is a malignant transformation of this, and here you have to go in for the radical parotidectomy. Parotidectomy. Does it make sense to you guys? I'll just revise it for you. So a pleomorphic adenoma, first of all, enucleation is kind of contraindicated. You never ever go in for the enucleation. If at all they simply ask you what is the treatment of choice for the pleomorphic adenoma, you can go ahead with the superficial parotidectomy. Why? Because most of these, 90 to 95% of the pleomorphic adenoma, they're involving just the superficial lobe, and just going in for a superficial parotidectomy will serve your purpose. The patient will be kind of treated. But if they specifically tell you in the clinical scenario that, you know what, there is a medial deviation of the uvula or something, then it is trying to tell you that the deep lobe of the parotid is involved, and here you have to go in for the total conservative parotidectomy, where you're removing the deep as well as the superficial lobe, but you're not touching the facial nerve. And if at all, finally, if they tell you that, you know what, the facial nerve palsy is present, then you have to go in for the radical parotidectomy. Okay, then you have to go in for the radical parotidectomy, where you're basically removing the facial nerve as well. Okay, I hope it makes sense. Now, moving ahead, what is the most common type of the intersusception? If I just ask you, what is the most common type of intersusception? What do you think? What is the answer over here? Is it like the colocolic, ilioileal, ileocolic, or the ileal? So the most common type of the intersusception, if nothing is mentioned, that is what is a ileocolic. Now, what is intersusception? Intersusception is a kind of a condition where there is something which is called as a telescoping of intestine into like one another. Because of this, the patient basically comes to you with a small bowel obstruction, and this is how the patient might present to you. Now, this was again the question was asked in the kind of exactly the same kind of an exam. in one exam, there were two questions which were based on your interception. So just have a look at this, guys. Comment on the diagnosis of a 65-year-old kind of man with an acute abdomen. So patient is coming to with an acute abdomen, maybe intestinal obstruction, and you performed in barium enema, and this is what you are basically getting. So what is this? This is what is a characteristic claw sign which you basically get in the ileocolic interception. Okay, I hope you are able. Okay, so I'm really sorry. You can kind of mark it as a colocolic interception. I'm really, really sorry. It is not a ileocolic interception, it is a colocolic interception. And what is pointing towards the colocolic interception? Old age. So what you need to understand is that when we are talking about the interception, the most common type in children and the overall, that is what is your ileocolic. But if they specifically ask you what is the most common type in old age or the old individual or something, it is colocolic. Does it make sense to you guys? I hope it makes sense. So this is the age was given as 65 year, and that is why the answer is definitely a colocolic interception. Okay. Now what you're basically saying, this is what is your barium enema, and you're characteristically saying that this is a claw sign. What is this? This is what is a claw sign which you're basically seeing over here, right? So this is what is a claw sign which you're basically seeing in the colocolic interception, right? Right. So that's it, guys. That's it for this particular thing. Thank you so much, guys. It was indeed a pleasure interacting with you. I hope you gained something out of this particular session. Hope to see you soon in some other session very, very soon. I hope to see you there. And yeah, if at all you have anything to ask me, please do consider. And at the same time, guys, I hope you're liking these particular sessions on the free classes on the YouTube as well as the special classes. I really hope that you're kind of liking it. And what I'm trying to tell you is that your exams are kind of nearing off. And even if the dates are not yet announced for your NEET PG, if at all you're the one who is preparing for the NEET PG and listening to this, what you need to understand is that you need to continue your revision. Please plan your revision sessions in 30 to 35 days and till the dates are announced. And after that, you can kind of reduce it down to 20 or 25 days. If at all any of you guys wishes to revise general surgery with me, you can definitely consider kind of becoming a plus subscriber. I'm coming up with a particular course in which I'll be covering the entire general surgery in 13 sessions. Okay, in 13 sessions, 2 hours each, so it is going to be 26 hours. And the 26 hours, the entire general surgery will be kind of revised by me. And at the same time, other educators are coming up with their own revision courses. This particular batch has already started. The surgery sessions are going to start from 26th and they're going to end on 4th. Between these particular dates, I'm going to have 13 sessions, 2 hours each, and the entire general surgery will be kind of revised with you guys. So if at all you're remotely interested in this, please do consider becoming a plus subscriber. And if at all you wish to subscribe it, please do consider using a promo code surgery101, surgery101, or you can use dr.pawan, whichever you want. Okay. But I'm not saying that you have to come and join it. It is definitely going to be helpful, but you need to understand whether this is going to be helpful for you or not. So you are your best judge. You can take your own decisions, but please, yeah, like if at all you wish to consider and you wish to revise general surgery with me, this is your chance. You can definitely come and do it. But again, I'm repeating, I'm not saying that you have to join it. Even if you don't join it, not a love lost. You can definitely revise on your own. But if you're someone who likes to revise along with someone, and if you at all like to, if you will like to revise it with me, I'll be more than happy to kind of do that with you. Thank you so much, guys. Have a great day. Happy studying. See you soon. Bye bye.